Hi guys, welcome to the Symptomatology series. I'm Dr. Vishal Gabale, and in the last session we discussed about the dyspnea. In today's session we'll discuss about the cough. I have tried to change the approach a bit. I hope you like that. So today we'll be seeing more of the writing, and let's start with the first MCQ. As we can see over here, a 45-year-old non-smoker male. He presents with chronic dry cough since 3 months. He denies fever, weight loss or night sweats, so that rules out the tuberculosis, right? He reports worsening of cough at night and after meals. So this is a very important feature of one disease which we're going to see now. A chest X-ray is normal, so that rules out the majority of the infective cause of cough as well. Which of the following is the most likely cause? Now let's see the options first. Considering the patient is a non-smoker, we can rule out, or we can just consider that the lung cancer could not be an option. Okay, so let's put a question mark over it. Let's say the second option, chronic bronchitis. So chronic bronchitis would have the productive cough. Okay, here we have the dry cough, so that's ruled out. Then gastroesophageal reflux, okay, that's something we can put a question mark again. And then sarcoidosis, no, because sarcoidosis you will have X-ray where lymphadenopathy is there. Okay, so in sarcoidosis, lymphadenopathy is very classical. So we have two options, lung cancer and the gastroesophageal reflux disease. Now, is there any history of weight loss? No, he denies the history of weight loss. Okay, or there is no clear-cut history of hemoptysis, right? So we can rule out lung cancer also. The answer for this question is GERD, because in GERD the cough is classified. Okay, so the worsening of the cough at night and after meals, it's a typical feature for the GERD, okay, which we're going to see in the coming session. All right, so with this, let's start with the discussion. Okay, so cough is nothing but a protective reflex for clearing airways of mucus, particles and irritants. Okay, so cough is a protective reflex of airway, and it helps to clear what? It helps to clear mucus, particles and irritants. Okay, so it can be anything, a mucus in the form of infective cough, or particles in the form of foreign body, or irritants in the form of certain chemical inhalation. Okay, so all this leads to cough. Now cough, whenever there is an impaired cough, that's also a problem, and whenever there is an extra cough, that's also a problem, because body tries to maintain our normal physiology just to clear the pathogen, right? So impaired cough means what? If whenever somebody is having mucus secretion, excess mucus secretion in the bronchus, and you are not able to cough, so that mucus will go into your lungs and will cause infections. All right, so impaired cough can lead to retained secretions, infections, and what? Also, it can lead to atelectasis and respiratory failure. And respiratory failure. All right, so if this video becomes a little slower to you because I'm writing, you can watch it in 1.5x also. Okay, so excessive cough, it can cause what? Again, so as I said, impaired cough or reduced cough is also problem, or excessive cough is also problem. So when excessive cough is there, so that will lead to your patient may vomit, so it can lead to emesis, it can lead to a syncope. It is called as cough related syncope. Okay, because the intrathoracic pressure rises a lot. We'll see mechanism very soon. All right, it can sometimes lead to rib fractures also because of the increase in the intrathoracic pressure. All right, then there can be hernias again because of the abdominal pressure rise, and some patients you can see urinary incontinence. Okay, even rectal incontinence in the elderly, particularly in the female. All right, so these are some important features. Okay, so cough is nothing but a protective reflex, and that helps us to clear airway of mucus, particles and irritants. Now if there is irritant cough, impaired cough, then that's also a problem, can lead to respiratory failure, and if there is excessive cough, then that's also a problem, because that can lead to MSC, syncope, even rib fractures, hernias, and urinary incontinence. All right. Now, when we talk about the mechanism of the cough, now let's see the mechanism of the cough. Okay. So, mechanism, it's very interesting actually. You must have seen this in the physiology, but it's very simple. So we have certain stimuli, receptors, and the afferent and efferent limb. Okay, so first of all, stimuli, then that stimuli will activate your receptors. Okay, we will see in detail, don't worry. Okay, then pathways, that is, first is your sensory pathway, that's your afferent. Okay, afferent, and then your efferent pathway. All right. So what's a stimuli? So obviously the stimuli will be something that's irritating. Okay, so particularly, for example, let's say a chemical structure like your capsaicin. Okay, so capsaicin is one thing, and when we talk about the mechanical, then that can be your mucus or air pollution. Mechanical in the form of mucus, right? Because you must have seen that whenever you have a sore throat or a cold, you get this mucus production, all right, and because of this you can develop cough. Okay, so that's a protective mechanism, nothing to worry about that. and even at a starting phase, if it's not disturbing you, don't give cough syrup right away, because you are suppressing the good mechanism, and that can also trigger some sort of serious infection if patient is immunocompromised. All right, so mechanical stimuli are mucus and air pollution. Okay, yes, so this stimuli will basically activate the receptors. Okay, so what are those receptors? So these receptors are nothing but these are ATP activated ion channels. All right, so these are ATP activated ion channels, and they are typically located in your lungs. Okay, so these are cationic channels. Okay, so these are cationic channels, particularly ATP activated ion channels. All right, so this is the one receptor mechanism. The other pathway is afferent. Now the receptors will go to the nerve stimulus, that's your afferent pathway. So afferent pathway or afferent center or sensory center for the cough, so this is very important MCQ, is located into the medulla. But how the signal goes to medulla? So with the help of vagus and superior laryngeal nerve, okay, SLN, that is superior laryngeal nerve, it goes to brainstem. Okay, and what part of brainstem? Particularly medulla. Okay, so this is a very, very important question for you all, right? Please remember this. Then we have efferent. So efferent is mostly like the signals from the brain will come to the particular part of your expiratory system for forceful expiration. So that particular part is a vocal cord, again, which is controlled by the vagus. All right, but it is mostly will help you to expirate, or to cause the contraction of the expiratory muscle very powerfully. So it leads to expiratory muscle contraction, and this expiratory muscle contraction is so powerful, it leads to dislodgement of the mucus. Okay, so it will eventually lead to dislodgement of the, sorry for the spelling, of mucus. All right, so let's see this mechanism what we just discussed through this diagram now. So see, first of all, there is a stimulation of the mechanoreceptors or chemoreceptors. So mechano means your mucus, etc., right? I got it. And chemo means whatever chemical is coming, for example, either airway chemicals or any airway pollutants as well. Okay, so this will activate throats, This will activate respiratory passages, stretch receptors in the lungs, and eventually from there the afferent impulses will go through the brainstem, that is medulla, and from there the efferent signals will come to the vocal cord, diaphragm, intercostal muscles and lungs, and that will lead to forceful expiration. Okay, so that will cause increased contraction of the diaphragmatic, abdominal and intercostal muscles, causing noisy expiration. Okay, so as we discussed, this is completely normal physiology. If it occurs in the excess amount, that's also a problem. If it occurs in little reduced amount, that's also a problem. Okay, so now with this, let's see in some phenomena where we can see the impaired cough. Okay, so let's see. So the causes for the impaired cough usually, as we know, is mostly because of the efferent problem, okay, or your motor problem, like the signals from the brain is coming but the muscles are not helping in a way. All right, so it occurs mainly, I'll just zoom it a bit so that I can write very well, due to muscle weakness. Okay, so the cause for the muscle weakness can be anything. Okay, that's very important. So this cause for the muscle weakness can be myasthenia gravis if it's very high in morning and going down in the evening. It can be GBS, it can be amyotrophic lateral sclerosis or cervical myelopathy. Okay, any cause that's involving these intercostal muscles or the chest muscles, that can lead to this. All right, so that's very important to note. Okay, so muscle weakness, particularly I'll just write down over here abdominal as well as intercostal, both of them, because both of them are important, right? Both of them are important. All right, then if there is excess pain to the person, then impaired cough can occur. If there is airway obstruction, that's very important, obviously. Okay, if somebody's airway is obstructed, how can he cough, right? That's very important. Or if there is abnormal secretion, like excessive secretions are coming and lungs is somewhat suppressed because of this. Okay, so for diagnosis we have like spirometry test, that is peak expiratory flow we can calculate, maximum expiratory pressure we can calculate, and we can get the idea of the muscles. Now one simple technique just to monitor the patient, or bedside assessment for the patient of the GBS and all, is a single breath count method. I hope you remember this. So if you ask the patient to count the number as much as possible in single breath, okay, if the number is close to 15 to 20, that's normal, or more than that, it's normal. But if it's less than that, that's less than 15 to 18, that's a problem for your patient. All right, so that tells us that the respiratory muscle are under fatigue. That's very important. So management, it's simply you can just splint the abdominal muscle with the pillow. Okay, so you can just splinting of abdominal muscle with pillow, or in complex cases you can give the mechanical cuff assist devices. Mechanical cuff assist devices. Okay, yeah, right. So now based on the duration, cough is classified into three main classes. First is less than 3 weeks, second is 3 to 8 weeks, and third is more than 8 weeks. So obviously if it's acute cough, the causes would be any respiratory tract infection, either viral or bacterial, or if there is a history of aspiration, or if there is an irritation of the airway. Okay, so if it is less than 3 weeks, it's acute. If 3 to 8 weeks, it's a subacute. If it's more than 8 weeks, then that's a chronic. Okay, so the causes for the acute, as we discussed, was respiratory tract infection. I'll just write it as a LRTI. Okay, so LRTI, or if there is an airway irritation or allergies, right, or even aspiration. All right, if it is subacute now, so subacute is slightly tricky. Here we have some specific causes. For example, your pertussis. Okay, pertussis is there, Bordetella pertussis, that causes that. Then post-viral cough. So you might have seen many patients coming to you with a common cold, and after that after a certain period they develop cough. So that's your post-viral cough, right? Or your post-infectious bronchitis. Okay, post-infectious bronchitis. All right, so this is a form of the infection, basically LRTA or pneumonias. or even viral pneumonias, where you can, or viral airway inflammation, where you can see the bronchus is involved. That's your post-infective bronchitis. All right. Now coming to the chronic cases. So chronic cases obviously will be asthma, wherever like prolonged duration is there. Okay. Then rhinosinusitis. So all forms of sinusitis. Okay. Then asthma, COPD, even some drug related cough like ACE inhibitor related cough. Okay. Even lung cancer, that's very important, right? Lung cancer. All right. So lung cancer also. Right. Now let's see the history points or the assessment of the chronic cough. It's very important point for your examination as well as your viva. It's commonly asked. So first of all, we'll ask for the duration, right? Because on the basis of the duration, we know different causes are there, which we just saw right now. All right. Then we have to ask for the triggers for the cough. Okay. So triggers for the cough, for particularly, for example, if somebody is having early morning cough, that's classically seen in the COPD cases. If somebody is having nighttime awakenings because of the cough, that's very classic for the pulmonary edema. Or if it's like very early morning, then that can be your bronchial asthma as well, but it's reversible. All right. Then even if patient is having some certain sort of allergies, then also it's atopy and bronchial asthma. Okay, allergic bronchial type asthma. Then apart from these triggers, now third point you should ask the patient is the sputum. Okay, is there is sputum production or not? So if there is sputum production, then you can think of chronic bronchitis, or you can think of bronchiectasis. Okay, and you also should ask for the color of the sputum. All right. So if the color is yellowish, then it's infective. If it's hemorrhagic, then it's either tuberculosis, malignancy, bronchiectasis. These are the main three causes. Even if it's a pink for the sputum, then it has to be pulmonary edema. Right. So color, I'll just write over here quickly. If it's pink frothy, then it can be pulmonary edema, right? If it's yellowish, then it's infective cough, right? It's pneumonia, infective cough. And if it's red colored, then it can be TB, or CA, or ear bronchiectasis. Okay. So this can be some causes of red colored sputum. All right. And then apart from that, finally you should ask for the worsening and relieving factors. So if relieving factor, that means a patient is taking certain medication and symptoms are relieving after that, so that has to be bronchial asthma. Okay. So worsening and relieving factors has to be asked. Now in physical examination, obviously, as we know, general examination is there, systemic examination is there. All right. In general examination, you definitely have to see for the signs of respiratory distress, which can be suggested by high or fast respiratory rate, tachypnea. Then if there is the use of accessory muscles of respiration, that could be one thing, and that basically tells you about the even tachycardia can also be there in some cases. All right. So that's about the respiratory, and even you can see pallor also. Okay, all these things can be there. Then talking about the systemic examination now. In systemic examination, overall, if you're that main breath sounds or the primary breath sounds, that's like bronchial breath sounds, vesicular breath sounds, all right, if those are disturbed, then you can identify there is a problem with the physiology. And or if there is a problem in the adventitious sound, for example, if you are hearing rhonchi or you're hearing wheezes, then it can be airway issue, right? Airway issue, you will hear rhonchi or wheezes, right? You guys know this rhonchi and wheeze, musical sound. And if there is a problem in the lung parenchyma, then obviously what you will hear in case of lung parenchyma, you will get the crackles. All right, crackles or creps. All right, so this is the basic distribution. I have covered it in the first video on the examination of the respiratory system in my YouTube channel. That's Dr. Vishal Gabale. You can check on that as well. Okay. Yeah. Now coming to the investigation, chest X-ray and sputum analysis will help us to get exactly the cause. All right. So chest X-ray mainly helps us to rule out tuberculosis, sarcoidosis, or lung cancer. All right. So for TB, CA, okay, or sarcoidosis, So this is basically your some DDs for which you can do the chest X-ray, and sputum analysis again for tuberculosis, mainly tuberculosis. Okay, so that will help you. Even some bacterial pneumonias can also be diagnosed, but it's very rarely or very low yielding. Okay, so this is the summary. In short, here we can see. Alright, so let's see protective function of the airways is by the clear airways. Like what are the function of the cuff? So first is it is protective function. It clears airways, prevents the infection, removes the foreign particles, as we all know, right? The second is excessive cough risk is there. So obviously we know if whenever there is a excessive cough, there can be refractures, syncope, urinary incontinence, social discomfort. Alright, so as we can see, refractures, syncope, urinary incontinence, social discomfort. Alright, so in final stages, as we discussed about the mechanism, like this stimuli will go to the medulla will give the efferent to the vocal cord muscles as well as intercostal muscles, diaphragms and abdominal muscles to cause the cough. Alright, then finally if there is a sometimes in case of respiratory muscle weakness, you can get the infrared cough. Cough duration we discuss acute, subacute, chronic. Then we discuss about the causes of the chronic cough, and then we discuss what are the diagnostic approaches in this case. Alright, so I have now a common approach that's given in the Harrison in the flow chart on how to approach the chronic cough. Okay, so let's see that. So with that, first MCQ we have for that is, which of the following is not a common cause of the chronic cough with a normal chest radiograph? Alright, so obviously in some chronic cases you will have normal chest X-ray. So this is now something which is really important, that for all of us we should know this. Alright, so let's see, ACE inhibitor use, yes, X-ray can be normal. Asthma, yes, X-ray can be normal. GERD, yes, X-ray can be absolutely normal. But tuberculosis, it's very important. Tuberculosis, the X-ray findings, right, either the fibrosis in the apical lobes, or you can see hilar lymphadenopathies, etc., or the Grons focus, etc. All those things can be there. Okay, then coming to the second MCQ of this topic of the chronic cough discussion or approach to chronic cough. So let's see this MCQ. A 45-year-old woman is there. So she presented with persistent dry cough, okay, for past 6 months. Then she had also some tickling sensation in her throat, which worsened with talking and laughing. Okay, so here it worsened with the talking and laughing. Now when she when we asked her for the history of fever, wheezing, heartburn, etc., so actually it was not suggestive of anything. So like majority of the things were ruled out by that. All right, so fever is ruled out, pneumonia is not there, wheezing is ruled out, so this is not a asthma. Also heartburn is ruled out, GERD is not the case, post nasal drip is also not the case. So what could be the condition now? Now let's see what X-ray says. So radiograph and pulmonary function test will also normal, and she was also previously treated for asthma and GERD with no improvement. That means GERD and asthma is not the case, because asthma is reversible, GERD is also, it can get better. So this has to be something else. So we rule out post-nasal drip, GERD, tuberculosis. The answer is cough hypersensitivity syndrome, which we're going to discuss in the next session. Alright, so now there are certain conditions in which even patient has chronic cough, the X-ray will be normal, okay, with the normal chest radiograph. So what are those conditions we are going to see now? Okay, so first of all is the most important, as I mentioned over here in the MCQ as well, is the ACE inhibitor use. ACE inhibitor use, as you know, because of the bradykinin component that is stimulated by the ACE inhibitor, you can see this curve. It is seen in 5 to 30% of the patients, all right, due to the bradykinin. And what is the treatment? As such, it doesn't have treatment. We just have to stop the medication, stop any class of the medication, and shift to the ARBs. Okay, then going on to the second, that's a post nasal drainage syndrome. Okay, here basically you will have the upper airway cough syndrome. Okay, so patient typically comes with the frequent throat clearing or a nasal congestion or sneezing like this. All right, so this can be there. So this is post nasal drainage syndrome. Okay, so this here it's also called as upper airway cough syndrome. Okay, upper airway cough syndrome. All right, here typically, as I mentioned, patient comes to with the throat clearing. All right, there is nasal congestion and frequent sneezing is there. Okay, frequent sneezing is there. Now coming to the third cause, that's your GERD. We all know in GERD cases, because of the reflux, it can trigger the cough reflex. Okay, so reflux is there, your stomach content is getting into the esophagus, and because of that the cough is there. So here you can give PPI for the management. All right, but make sure if patient is not having any functional dyspepsia or something like that. Okay, yes. Coming to the fourth cause, sorry for this. Okay, so the fourth cause is your asthma. Okay, so asthma, bronchial asthma can have some of the times, even patient is not having any wheezing or dyspnea, only cough can be there. Okay, cough can be there, and that could be one of the chronic cause of cough with normal X-ray. Obviously normal X-ray will be there in asthma. Okay, then fifth is your eosinophilic or allergic eosinophilic bronchitis. Okay, so obviously your blood will have the eosinophilia, sputum will have the eosinophilia with eosinophils more than 3%. It's very important. Okay, even lung functions will be normal, and patient will have excellent response to inhaled corticosteroids. Okay, so last few points now. After discussing these causes, like ACE inhibitor was there, post nasal drainage syndrome was there, then GERD was there, asthma was there, and eosinophilic bronchitis is there. Now let's see what is cough hypersensitivity syndrome. That's one MCQ also we saw, right? That even with treating everything, cough was not getting better. So here, cough hypersensitivity, as the name suggests, it's occurring because of the increased sensory nerve sensitivity. Okay, so it is because of the increase in the sensory nerve sensitivity. That's your vagus, right? That's your vagus. So all these receptors basically they activate extra. Okay, they're activating extra to the vagus. Okay, and because of this, patient usually have some sort of tickling sensation in the throat, and it's usually worsened by talking, laughing, exertion. All right, so there is a tickling sensation in these cases. Okay, and it's usually worsened with laughing, talking, okay, or even exertion. All right, so yes, and it is more common in which group? It's again more common in the women. Okay, so maybe a kind of defense mechanism for women, but yes, we have majority of the cases in the women as a cough hypersensitivity syndrome. All right, so as such, it's very difficult to manage such cases. All right, yes. So then finally coming to the diagnosis and evaluation. So as we already discussed, so we go step by step. First we will do the history physical examination. All right, and then we will do the routine evaluation like CBC, sputum analysis, chest X-ray. Okay, so routine like CBC, chest X-ray. All right, and then finally we will do the radiology. For example, even PFT is your routine. Okay, radiological in the form of CT. Okay, CT scan. That's done if there is a no improvement or if you suspect some bigger cause. All right, so that's all about this. Now finally let's see the treatment approaches for the cough. Okay, so if somebody is having post nasal drainage, those sensation or throat clearing frequent, all right, this is in these cases we have to give antihistamines. Okay, antihistamines, you can give decongestants also. Yes, this can be given. GERD, you guys know PPI has to be given, and lifestyle changes. Okay, lifestyle changes, like ask the patient to not lie down just after eating. That's very important point, you all know that. Then eosinophilic bronchitis, as we discussed, inhaled steroids as a role, right? Okay, cough hypersensitivity, so here you can give gabapentin, but that's off label use. As such, we don't have any medications. Okay, so off-label you can give gabapentin, etc. Okay, even amitriptyline, it's excellent antidepressant as well. Okay, as well it helps in this condition. And for asthma, which is a cough predominant type of asthma, you can again give ICS. Again, that's the same treatment. Okay, beta agonist, either LABA, SABA, depending on the stage of the bronchial asthma. All right. So then coming to the symptomatic treatment of the chronic cough. So if you have chronic cough, for example, if it's a productive type of cough, then we give the cough suppressants, either in the form of codeine, hydrocodone and morphine. All right, so that will be effective, but sedation will be one of the side effects for it. Okay, so sedation is positive or plus, right? So, and there is also addiction risk is there in these cases. Okay, addiction risk is there. So all the old people coming to your OPD, most of the times in the government setup where those are cough syrups and all easily available, are for these reasons. Okay, they get sedated, they are kind of addicted to this. All right, then coming to the dextromethorphan, so this is easily available OTC. Okay, and it's also again less effective than the opioids though, but yeah, its side effects also are less predominant. All right, then we have benzotenate. Okay, benzoate, sorry. Yeah, so benzoate is also one. As such, no major side effects. It can also be used. Okay, no major side effects, so it can also be used. Then inhaled lidocaine, actually it helps us in some way, but it's only transient relief what we get it from. Okay, so it just provides transient relief. Okay, but it risks the aspiration. Okay, yes. Finally, general considerations, for example, air pollution indoor and outdoor as a cause of chronic cough. So that's something, you know, in recent era, because of the pollution is increasing, that's also a very important cause of the chronic cough, and we have to take care of this. And even tuberculosis should be considered as a in endemic region. So for example, in India particularly, we have lots of cases of tuberculosis, so chronic cough we have to rule out that. All right, so considering the threat of air pollution and tuberculosis, these are a global consideration advised by the WHO to all the countries. Okay, to whenever the patients of chronic coughs are there. All right, so that's all for the discussion of the cough. All right, if you have any doubts, you can ask me in this comment section, and what kind of lectures you want to see in the upcoming session, you just let me know. I hope you enjoyed this session. Thank you so much.